So UFE's changed a lot over the years, even since I trained, but even in the last 10 years since we've been doing this here in the office. When I trained, the procedure was done in the hospital. We would go in through your groin. We would do the more complete embolization, where we just kind of showered the entire uterus with these particles. And patients had a lot of pain, a lot of discomfort. It's probably why when you'll read a lot of stuff on the internet, you'll hear these stories about patients that had this intractable pain afterwards. It was so painful, they had all these issues. They spent a couple of days in the hospital with a pain pump. What we've learned over the years is that we don't have to block as much of the blood supply to have sufficient outcomes. And so now we're much more focal. We go further out, we embolize directly to the tumors versus kind of showering everything with the particles. But the big changes really have been in some of the equipment and some of the techniques. We now exclusively go through the wrist if we can. The reason that we do the wrist is the recovery is a lot better, the procedure's faster, the procedure's safer. If we go through the groin, you come out, you have to lay flat. We have to put a little plug to plug up the hole, which dissolves over about 30 days, but it can be uncomfortable. And the risk of bleeding from the groin is small, but there have been serious complications from bleeding from the groin versus in the wrist. The artery is so close right here, we put a little wristband on the wrist that has a balloon that just holds pressure for about an hour, and then you go home with a Band-Aid on the wrist. The reason we didn't always go from the wrist is because honestly they didn't have the catheters long enough to get all the way down to the uterus and all the way out to the fibroids. Even since in the last 10 years that we've been doing this, we've worked with some of our industry partners to help collaborate on, give them different ideas, just because we do such a high volume of different tweaks they can make to some of their equipment. We've now got catheters that are even longer in the last couple years, that are more flexible, that can go further, that are smaller. The particles that we use are much more precisely sized. And so all of those things has led to just a more refined, a more delicate, a more kind of, I don't know, I guess refined is the best word, but a more refined procedure where it's just more focal, more targeted, and we don't do as much, have as much effect to the surrounding normal tissue as it potentially could in the past. We work really closely with all of the healthcare team. A lot of our OB-GYNs that we work with, they refer us patients we collaborate with. Certain patients we talked about will have a really large uterus, and we can tell them, we know that we can help your bleeding, we know we can help with the size of the fibroids, but in your case they have a really petite frame or the uterus is just really big, then we're worried that even though we're going to get that size reduction, they're still going to have some bulk symptoms afterwards. And so in some of those patients, we'll actually plan to stage the procedure. Some of the OBs will actually send us these patients to do the UFE, to shrink the uterus as much as we can, to control the bleeding. And then if they come back in and do a myomectomy, or in some cases even a hysterectomy, they can do it with a smaller incision and they can do it with less blood loss. And so it's a safer, more effective procedure. And so they'll send us those patients preemptively, or sometimes when we see patients that have really large fibroids, we may try to coordinate with them in that case. There's also the case where patients can have fibroids that are inside the cavity of the uterus, and those fibroids are at risk of passing after the procedure. And a lot of times if they're small, they'll just pass out through the vagina. We'll tell patients, hey, in a couple months you may notice this come out during your cycle, kind of like clotting, and we'll just monitor them. But if they're really large, or if the patients haven't had a vaginal delivery in the past, there's a chance that those fibroids could be stuck inside the uterus, or that they could just begin to pass, but it could take quite a bit of time, and sometimes it can be months of just bleeding or spotting. And so in those cases what we will do is we'll still do the embolization or the UFE, but then we'll schedule the patient to go in and see one of our partner OBs, typically within 2 to 3 months after the procedure. And what the OB can do is, in the surgery center, can go in through the vagina with a scope, dilate up the cervix, scrape out and remove any of that residual tissue that's inside the cavity. And that way you don't have this continued passage of this material, and you don't have a risk of infection. So it's a really great kind of combined procedure. And then again, we'll have patients that come in and see us that are actively trying to get pregnant, and they're having trouble with fertility. And in those cases, if they're within their childbearing years and that's their main goal, a lot of times we'll send them out to our referring doctors or to our partner physicians, and say, hey, look, this patient isn't a great candidate for us, but I think maybe they could benefit from one of the other procedures to help them with their fertility goals.